All right, so good morning, everybody. For those of you who don't know me, my name is Kyle Goulet. I'm the EMS educator for Middlesex Health here in Middletown. Part of my roles here is doing things like this, so outreach to our sponsored services when there are things worth reaching out about, which this Connecticut EMS protocols were just updated the end of December, I want to say it was. So we're here today to kind of summarize those changes and really answer questions and give our sponsor hospital kind of view as to what we're endorsing, what we're not endorsing. So to start, what we'll do is we'll do a little bit of a background here of these statewide protocols because they really haven't been around for that long in the grand scheme of things. So if we kind of go back in time to 2016, that was when the initial statewide protocols were released. It was kind of the version one. And the thinking behind it was to really get everybody on the same page for the most part. Now, I say for the most part because there still are things and protocols that are sponsor hospital dependent. An example of that would be like glucometers. So if a service wants a glucometer and has the approval of the sponsor hospital, BLS services we're talking about, then they can absolutely do that, and as long as there's that additional training aspect to it. An example of a protocol that's absolutely statewide is CPR. So you can't opt whether you want to do CPR or not do CPR. It is an across the board thing. So there is a little bit of flexibility here from a sponsor hospital perspective, and that's really what we're here today to provide is clarity on what the sponsor hospital portion of the updated protocols are. So 2016 was the initial. 2018, we saw some small changes, mostly at the ALS level. Ketamine was starting to come around for pain management. 2020, COVID hit, and we started doing things, or we started not doing things like giving nebulizers or CPAP treatments for suspected COVID patients. And there was a AHA update right in the middle of COVID that kind of got swept under the rug a little bit, and rightfully so. But every 5 years, AHA updates its guidelines, and the state has those corresponding updates. 2022, 2 years ago, we met and did a similar rollout. And the big things that came around out of that update were pelvic binders were worked into the guidelines, and the naloxone leave behind program for leaving behind naloxone kits to friends, family members, coworkers, whoever, for opioid overdoses. And at the ALS level, blood transfusions really started to gain ground. So here we are in 2024. And what I will say is that at if you read kind of the summary of changes documents, it's what we'll look at in a sec here. It looks like it's a really long, exhaustive list of lots of updates, but really there's not anything that's huge. There's a lot of small things. We kind of reworked CPR a little bit, actually simplified it a little bit, but multiple small changes, multiple updates, a lot of clarifications, but nothing really kind of groundbreaking or earth-shattering from a patient care standpoint. We're going to start and kind of work this from kind of most confusing to least confusing. But before we get into that, I'll put a kind of plug in here for the OEMS website. And on the website, I probably Google this 15 times a day, CT, DPH, paramedic protocols, or CT paramedic protocols, or EMS protocols, or whatever. It'll lead you to this page. If you scroll down on this page, you'll see all the old versions of the protocols. But at the very top, you'll see links to PDF documents of 2 documents. So the one on the left here is the complete document that's 270 some odd pages of patient care protocols. On the right, this is the summary document that came out in December. And it really goes through kind of protocol by protocol and says, hey, in the overdose protocol, this is what changed, and here's the reason why it changed. So it's a really good document. If you haven't had the chance to kind of look through it and you look through it and read it for yourself, I do recommend going to that OEMS website and taking a look at that summary document there. So like I said, we're going to start with the most confusing and most ambiguous kind of changes, and then kind of work into the easier stuff a little bit here. So we'll start with what the state is calling a scope of practice change, and understand that this change is a legislative mandate. So what that means is it goes through the legislator, a representative proposes a bill, and there's a change to statute. And that's a little bit different than a change in protocol, but a change in statute almost forces a change in protocol. So what I mean by that is, if we were to say, like, one of the changes we're going to talk about today is going back to kind of the traditional 30-2 CPR. That's not a scope of practice change, because CPR is within the scope of practice of every level of provider. The way in which we do it is kind of a protocol matter, and that's a DPH matter. It's an OEMS matter, a protocol committee matter. Scope of practice is things like allowing EMRs to do intramuscular injection. That's outside of the national scope of practice, so it needs to be a legislative change in the statute to allow EMRs to do that. So there were two kind of scope of practice changes that are very, kind of similar and related. And this memo was a communication put out by OEMS in, I believe it was August of last year. It outlines two big changes. At the top, it's the EMT, EMR, intramuscular naloxone. So what this says is that if you have a patient that is, a suspected opioid overdose, that you would typically give intranasal naloxone to. So same patient population, same everything. Instead of giving it as an intranasal administration, the scope of practice now allows for intramuscular administration. So that would be drawing naloxone out of a vial and injecting it via an intramuscular injection in a similar way in which you would inject, say, epinephrine for anaphylaxis. The second piece of this was to allow EMRs to administer epinephrine autoinjector for anaphylaxis. So again, same rules that EMTs have for administering an epinephrine autoinjector. So signs and symptoms consistent with anaphylaxis and all of that. But that scope, that EMT scope of epinephrine autoinjector, is simply extended down to the EMR level. Now, there is a little bit of ambiguity within these, especially the EMR epinephrine autoinjector piece of this, because of the way that the legislation is written. It's a little bit unclear whether this is going to be a mandatory thing or whether this is going to be kind of a sponsor hospital approval thing. The other piece of this is written into the legislation. As written, it's a little ambiguous as to if a service opts to go to this EMR level of auto injector. There's something written into the legislation that says EMR response vehicles, or maybe that's not the correct wording, but something similar to that. All EMR response vehicles should be outfitted or equipped with an epinephrine autoinjector. So we're not really sure how they're defining what a response vehicle is. So, does that necessarily mean that every police cruiser that has an EMR on it now needs an EpiPen? Does it mean that if you're a first responder responding from home with a jump kit, does that mean that that's now a first responder vehicle that needs to be an auto injector pen? And the state DPH really doesn't know, and they've reached out to their legal counsel for clarity on it, and unfortunately that clarity just hasn't come through yet. So there'll be more to come on that, and as we get the information in, we'll communicate that out. But we have done a couple of things with this at the state level, at the sponsor hospital level, that we're going to kind of get into next year. So the first thing that we'll look at is the first protocol we'll look at here is this poisoning, overdose, substance use disorder. And this is what we're really talking about here for the purposes of today. We're really talking about opioid overdose. So again, that population that is known or suspected opioid overdose, respiratory depression, the whole picture. The patients that we would typically give intranasal Narcan to, the state is saying EMR providers can give, EMT or EMR providers can give intramuscular naloxone drawn from a single dose vial. So what that would look like is you would have a syringe, a needle, a vial. You would draw out of that syringe, needle, and vial your dose of naloxone, and then administer it as a intramuscular injection. Now, us as a sponsor hospital, we're not endorsing intramuscular naloxone for EMRs or EMTs at this time. And the reason for that, excuse me, the reason for that is in our community, there simply isn't the need. So from my understanding of the origin of all of this, it came from a service that was really kind of burning through a lot of Narcan very, very quickly, as I'm sure a lot of us are. And they were having a little bit of a difficulty getting the nasal administration version of the naloxone. But what they did have within their stock at their community health center or something similar was a lot of these 0.4 milligram vials that were not being used. So they said, well, if we're having a hard time getting the nasal version, why can't we just use this 0.4 milligram kind of stockpile that we have? And so it was written into kind of the legislative change that this intramuscular dose is allowed. Now, one of the dangers of intramuscular versus intranasal is quite simply introducing a sharp into an already potentially chaotic scene. And it's our opinion that introducing a sharp is a risk that really isn't worth the reward, especially since we have nasal Narcan in our area, at least, fairly readily available. So this may be revisited in the future if nasal Narcan becomes more difficult to find. And if that is the case, then there'll be a communication that comes out from either Jim or Dr. Zanker to communicate that, and we'll issue out some training on how that process works. But it would really be similar to the if you remember the Epi Check and Inject program that came out a few years ago from the state. It would really be that a very similar program to that, but replacing the epinephrine with naloxone. Now, the other thing we'll kind of mention here is that the focus in these opiate overdoses oftentimes goes to naloxone. In reality, it should really be going to airway and ventilation support, right? So the first line treatment for these patients is, opening the airway, ensuring an open airway, and then providing that BVM ventilation. And ultimately, if you're able to provide that BVM ventilation appropriately, the emergency is really over. The naloxone is a secondary treatment. The primary treatment is ensuring those adequate ABCs. But another kind of plug in here, don't forget that SWORD report. It's that statewide opiate reporting, I forget what the D is, directive maybe. And this is the call to poison control after a opiate overdose. And you really are telling them kind of the basics of, where it was, what happened, was naloxone given, was it not given, did it have an effect, was the patient transported, did they refuse, all of those things. Now, our guidance to our paramedics is if there is a paramedic on this scene, which a lot of the times there is, our paramedics are making that report. If one of our paramedics is not on the scene, then it becomes whatever the highest level of care on that scene is. So don't forget to do those SWORD reports when appropriate. The state does track that data to kind of find the hot spots around the state of where there's an increased prevalence of opiate overdose. And they do that to kind of track like where there may be some, quote unquote, bad drugs or bad batches out in the community. So they can, kind of track that and from a public health perspective. The second kind of change related to this intramuscular administration is that the EMRs can now, in the state guidelines, EMRs can now administer epinephrine auto-injectors, or, what we commonly call an EpiPen, but whatever manufacturer or brand that you use. So on the screen here, you'll see the allergic reaction anaphylaxis guideline. The adult version's on here. The pediatric version is really exactly the same, except for the dose of the epinephrine's half. And this is something that Middlesex Hospital is endorsing. So there's kind of a two-pronged system here. At the EMT level, check and inject IM epinephrine is something that's been around for a while, and that training is available through DPH with some stipulations surrounding it. The EMR auto-injector portion of this is not available through DPH yet. It just hasn't been created yet. However, we did create an instructor toolkit through Middlesex that's approved through the state to be used for our sponsored services. So if you are a sponsored service of Middlesex that has EMR providers and you wish for them to carry and administer EpiPens, that's something that you can work with us with, and we'll provide you either with training directly on how to do that, or we'll do like a train the trainer type of situation and provide you with all the resources that you would need to do that training at your service. So if anyone is interested in this EMR auto injector program, you can shoot me an email or shoot Jim an email, or and we'll work with your service to figure out a way to get you what you need. Right. Last kind of piece of this intramuscular thing isn't really a scope of practice change, but at the EMT level, they've expanded the use of epinephrine into severe asthma. So this is one protocol that we as a sponsor hospital are a little bit hesitant on. We have some communication into DPH for some clarity as to whether this is something that is one of like the necessities that is not a sponsor hospital thing, but a state thing. We don't have any clarity on that quite yet. But what the protocol says is that we have if as an EMT, if you have a patient that has a known history of asthma and impending respiratory failure, so this is your really severe asthmatics kind of on the brink of decompensation and death, you can administer an epinephrine, 0.3 milligrams of epinephrine intramuscularly it's the exact same manner that you would administer it for anaphylaxis, whether that be via auto injector or check and inject. But instead we're administering it for asthma, right? So the process has changed, or the process is exactly the same, but the indication now includes severe asthma. Now, understand here, and I really want to stress this point here, is that epinephrine is a very potent medication, and it should only be given in the absolute most extreme circumstances. It must be given with absolute extreme caution, and this should be an exceedingly rare occurrence. Now, I kind of pulled our medics within Middlesex here, the ones that have been here for a while, your Mike cases and whatnot, and said, how many times can you remember in your collective hundreds of years of experience have you administered epinephrine for asthma? And as a group, the number was less than 10. So this should be an extremely rare occurrence. Now, understand, if we're giving epinephrine for anaphylaxis, there's huge risk there there's huge benefit there that outweighs the potential risk. Because anaphylaxis is something that's relatively clear cut, stung by a bee, shortness of breath, tongue swelling, like it's a pretty obvious presentation. But the presentation of asthma as compared to, say, maybe a CHF exacerbation or, really bad pneumonia or even anxiety in some instances isn't necessarily as clear. To the point where in the hospital, they're not necessarily, in some cases at least, they're not necessarily making that delineation between something like asthma or COPD versus CHF until really chest x-rays and lab values. So in kind of the pearls and the notes surrounding this protocol change, it says right in the protocol, you have to be absolutely sure that this patient is, number one, asthmatic, right? Having an acute asthma attack as their problem with no elements of CHF or no elements of kind of any other condition going on. So just a straight up really bad asthma attack and nothing else going on. And they have to be in impending respiratory failure, kind of about to die. So what the guidance in here is, if you're not absolutely 100% sure that it is asthma and asthma alone, and you're not absolutely sure that they're in respiratory failure, this is not a medication that you should be administering. And again, I feel like This is such a rare occurrence on the ALS side. It should be as rare, if not rarer, on the BLS side. So we really kind of advise against this. If we are allowed through the state to not allow this for our sponsored services, that's exactly what we're going to do. And if we are allowed to kind of veto this, communication will go out from Jim and Dr. Zanker to leadership of the sponsored services, indicating such. Now, as a kind of just an educational point here, I think it's important to understand the differences between respiratory distress and respiratory failure, because I think it's something that's really kind of commonly misunderstood. And think about respiratory failure as muscle failure, right? And that's where that term comes from, is it's failure of the respiratory muscles to do what the respiratory muscles do for us. So that's the diaphragm, it's the intercostals, it's all of those kind of accessory muscles that are used in chest wall expansion and the ability to really take a breath. So if I'm in respiratory distress, my airway is going to be open, it's maintainable, I'm moving air, right? I might be having a hard time doing it, but I'm getting the job done. When I'm in respiratory failure, I start to lose my airway because I start to lose my mental status, and eventually becoming unresponsive and entering into respiratory arrest and cardiac arrest, and we kind of go down that rabbit hole. Now, the next few things here, what we'll see here is that with respiratory rate and WOB on the screen is work of breathing, we're going to see an increased effort and an increased rate in distress. And then we're going to see that kind of peak during failure, right? They're going to be breathing difficult, having a hard time breathing, then worse, and then everything kind of drops off. And that's the real kind of indicator of failure, is they go from breathing, 30, 40, 50 times per minute to dropping that respiratory rate down to something slow. Same with the effort. They're working, and then the effort goes completely down because they're all tired out. Their muscles aren't working. I equate it to, maybe you're going to the gym and you're doing the bench press, and the bench press is going, you do your first couple of reps and you're able to do it. Then you start to have a little bit more difficulty, lifting the weight. Muscles start to shake a little bit. We're probably approaching failure at that point, but eventually we get to that point where no matter how hard we're pushing those weights up, they're not going to move, and we're at muscle failure. That's what respiratory failure is, if you kind of make that correlation there. Air movement, same sort of thing. In respiratory distress, they're moving air. They're just having a hard time doing it. But in respiratory failure, they're really not moving any air anymore, or they're moving not as much air as they need to be moving. Heart rate kind of mirrors our respiratory rate, where we're becoming tachycardic and compensating until we reach this extreme tachycardia, kind of maximum compensation, and then completely falling off and becoming bradycardic and eventually losing that heart rate altogether. Perfusion, kind of same picture here. Your respiratory distress patients, we've all seen them, pale, maybe a little bit diaphoretic. When we start to see like cyanosis and they start to get almost like that modeling type of thing, that modeling like purplish presentation, we're at failure, kind of impending arrest, and really kind of going down the drain quickly. And level of consciousness, I think, is the biggest kind of indicator. All of these things, individually are indicators, but I really think of level of consciousness as being, the easiest one to see, and the biggest kind of negative finding to really indicate failure. So in distress, anxiety, agitation, we have catecholamines running through us, and epi and norep, all these different things, and we may get a little agitated, might get a little tremulous. When the confusion starts to hit in, and specifically the lethargy starts to hit in, and some of you kind of maybe you can relate to the head bobbing while sitting, where they're breathing, but their head starts to bob down. And I always kind of think about it as you're going back to childhood and thinking about grandpa sitting in at the recliner after the big meal, and he's watching the football game, and then his head starts to bob down, like that same sort of head bobbing, but you're tired out from breathing versus tired out from a big turkey dinner. Really, really bad finding. That's respiratory failure. But eventually, obviously, the level of consciousness ends in a stupor, then unconsciousness, and we kind of go worse here. So unless we're in kind of this middle column, right column, I would say even more so the right column here, as a result of a severe asthma attack, epinephrine really isn't indicated, right? So if they're really breathing, quickly, or they're breathing, or they're tachycardic, or they're still mentating okay, really epinephrine is probably not indicated in those patients. It's really not until we get into that failure and pending arrest population. Next one that we have here is this behavioral emergencies. So the title here says adult and pediatric. This is specific to pediatric, and this is the state allowing transport to what's referred to as an alternate destination. And really kind of big picture is this is, in my opinion at least, this is one of kind of the first kind of building blocks for what may end up being like a mobile integrated healthcare or community paramedicine, or those terms get thrown around a lot. But this is really what we're talking about here is if we have a patient that meets certain criteria that are outlined in the guideline here, so it's 4 to 18 years old, depression, anxiety, emotional, behavioral dysregulation, substance abuse, self-injurious behavior, that type of thing that don't require medical intervention. So they're not requiring any medical intervention. So there's no injury, there's no evidence of overdose or anything like that. It appears to be strictly behavioral or psychiatric. We have the ability as EMS providers to transport these patients directly to what the state's calling a pediatric urgent crisis center. So there are 4 of these pediatric urgent crisis centers in the state. One is in New Haven, one is in New London, one is in Hartford, and one is in Waterbury. The 4 centers combined have 72 beds that are not necessarily available, but they have a 72 bed capacity combined. And the process for transporting to one of these is that you contact these urgent crisis centers directly and kind of give them the report. And then that urgent crisis center, based on your report and based on your your kind of explanation of what's going on, really makes a decision that, yeah, this is a candidate for coming here, or no, they're not a candidate for coming here. And how that decision is made is really up to that specific urgent crisis center. But the big thing here from an EMS perspective is quite simply there's no mechanism for funding these transports. So if you're working here in Middletown and have one of these cases of a patient that is potentially a candidate to go to one of these urgent crisis centers, and you make the phone call and you travel further than you would ordinarily with these patients, and you're bringing them down to New Haven or up to Hartford, or wherever you're going to go with them, and you get there, you're not going to be paid for that transport. There's no mechanism for insurance to reimburse that based on the way that the regulations are written at the state level of really really billing for transport to an ED from an emergency standpoint. So for that reason, we're not endorsing this for our sponsored services as of yet. We think that this reimbursement piece is something that is a really, really kind of big part of this. And also, the process of transporting these patients isn't really clearly defined. So one of the biggest things on here, it says on here, is they need to be voluntary, right? So the 3rd bullet here, receiving care at a urgent crisis center is voluntary. If physical or pharmacological restraint is needed or they're not willing to go, it's not an appropriate destination. So the question that I have is, if we're bringing a 12-year-old out to one of these urgent crisis centers and they get there and they no longer want to go, like, what happens? Does that become, do we turn around and go to the ED? Does that become a 911 call at that urgent crisis center? And we're not really clear on that. So, until this is kind of clarified and kind of fine-tuned, and that reimbursement piece is the one of the big ones here, we as a sponsor hospital are not going to be endorsing this. Seizures is very, very, very small change to the seizure guideline here. So we see, the old guideline here, and the only change here is outlined in red here. So previous, on standing order, EMTs could assist with the administration of rectal, usually diazepam, for seizures. And this diastat was something that was prescribed by the patient's physician, and the caregiver parent was basically given directions by the physician of how to administer this. And at the EMT level, EMTs are allowed to kind of assist with that rectal administration. And so really it's guiding the parent on how to do that. More and more prescriptions are being handed out for nasal versions of these medications versus the rectal version of these medications. So the only update to this guideline really says that you can still assist with the rectal diastat, but if the prescription is for intranasal medication, which is either going to be midazolam, or better known as Versed, or diazepam, better known as Valium, if it's a nasal version of these medications, EMTs can assist with that nasal administration. Now, the intranasal administration of these medications, collectively called benzodiazepines, it's a nasal administration, the same as you would give intranasal Narcan, right? So the process or the skills component of this is exactly the same, identical as giving Narcan, except you're giving a different medication. So the indication for this is going to be laid out on that prescription. So it may say for seizures lasting more than 3 minutes or 5 minutes, or whatever, administer this medication. And as long as you're within that medications, or as long as you're within those indications as laid out by the physician on the prescription, fire away. Have at it. But again, assisting the parent, caregiver type person with that based on the physician's instructions. Now, the other thing that's not on the screen here, but I put it down in the notes here, is the state kind of clarify the definition of status epilepticus. And for years, there's been, I don't even know how many different definitions of this term. And it typically kind of the question is around, well, is it a seizure lasting more than 5 minutes? Is it more than 10 minutes? Is it more than 15 minutes? Is it more than 2 minutes? So the state kind of formed an opinion on this in consultation with advisory boards and committees and whatnot. And the current definition that the state's using for status epilepticus is one of two things: a seizure lasting more than 5 minutes, or recurrent seizures without regaining full consciousness. So if I have a seizure that lasts, 1 or 2 minutes, and then I'm post-ictal and never kind of come back to full consciousness, and then I have another seizure, that's considered to be status epilepticus from a definition standpoint. All right, moving forward. Cardiac arrest is where I expect a little bit of pushback here. But we'll kind of go through what the changes are and what the reason for these changes are. So the biggest change is outlined in the red here, under ventilation and compression options. So if you have a BLS airway in place, so no advanced airway, no ET tube, no supraglottic airway, kind of traditional BLS airway, we are doing 30-2 always. Well, almost always. There's one small exception to that. So what this means is the business of what we were calling CCR is out, right? So in the previous versions of the protocols, there was guidance that if you have a witness or a cardiac arrest believed to be cardiac in origin, so dying of a heart attack or something cardiac related, the guidance was you could give 8 minutes of continuous compressions, basically put an OPA in and a non-rebreather on them, and not provide ventilations for the first 8 minutes of the arrest. That guidance was published in the original, I think it was in the original 2016 guidelines, based on research that looked promising, but turned out to not really be as great as everyone thought it was going to be. So CCR is out, 30-2 for adults. 30-2 is the, kind of the new standard, but which, aligns with the AHA perfectly. The other recommendation here is that the 2-person BVM is strongly preferred. And this is something that has been the recommendation for as long as I've had a CPR card. It's always been two-person BVM is preferred over a one-person BVM. So this is just listed in the guideline now as a strongly preferred recommendation. And the way that I kind of interpret that is if you have three people or three or four people, one person is doing compressions, two people are doing the BVM, and one person is, getting that AED on and ready to go. But this two-person BVM, it's listed in the cardiac arrest, but really this should apply anytime you're doing BVM ventilation, whether it be for an opiate overdose or a cardiac arrest or anything in between. Anytime you're doing BVM ventilation, the two-person technique is strongly preferred and has been strongly preferred. And we're going to give the guidance to our paramedics to really kind of reinforce this on the scene. So if you forget, the paramedics should be telling you, hey, if you're doing BVM ventilations, grab a friend, find a friend and tag team it. So CCR out, we talked about that. The only exception to the CCR thing being out is a relatively rare occurrence, fortunately, where you are in the back of the ambulance alone and the guy dies right in front of you. So if that happens, you can do continuous compressions until somebody else arrives. Right. So we're not doing, and this is a, exceedingly rare occurrence. So we're alone in the back of the ambulance, patient dies in front of us. We do chest compressions until somebody else shows up. And that's, or maybe not even in the back of the ambulance, but we're the only person on the scene. We walk in, we're talking to the guy before anyone else arrives. He keels over in front of us. We start our continuous compressions, and again, until somebody else arrives, and then it's switched over to the 30-2. The thing that people don't really like here is that the Lucas, by the state's guidance, the Lucas should be only applied after 8 minutes. And the reason for this is the first 8 minutes of a cardiac arrest are really the most vital. And any interruptions in chest compressions within those first 8 minutes have been shown to really decrease the chances of return of circulation and decrease survivability. Now, when we did the lives or the in-person session of this the other night, there was a bunch of questions about this. So before you ask them, I'll kind of address them. The thing is when protocols are written, they have to be written based on what the evidence and what the literature show. And what the evidence and the literature show is that there is no advantage of mechanical, I shouldn't say Lucas, but mechanical CPR or whatever vendor you're using. There's no advantage of mechanical CPR versus manual or person compressions by us in means of survivability. So if the two things are kind of equally effective, but the Lucas or application of the Lucas or whatever device you're using at your service, if you're using one at your service, has been shown to stop compressions for, longer than manual CPR. So if the two compressions, when I say compressions, I mean the rate, the depth, all of those things are comparable, but one option offers, or one option causes pauses and compressions, but we have to kind of lean towards the option that doesn't cause pauses and compressions. So the state, kind of understanding this, that these Lucas devices are very, very valuable, especially when it comes to things like patient movement and patient extrication and things of that nature. Still something that can be used, but really the goal here, and the goal has always been, that we're not stopping compressions for any more than 10 seconds to put it on. And we're waiting until those first kind of 8 vital minutes when everyone's really kind of coming in and getting settled. And, we're starting compressions and we're getting the story and we're putting in OPAs and the paramedics arriving and starting IVs and, a lot going on and all these different things. At that 8-minute mark, go ahead, put your Lucas on or whatever device you're using. And if it takes kind of 2 cycles of CPR to put it on, that's absolutely fine. So maybe at one rhythm check or one pulse check, you're putting the back plate under the patient and then doing another 2 minutes of manual CPR. And then when we stop compressions to do another pulse check 2 minutes later, we're putting on kind of that plunger top piece. That's absolutely fine to split that application up over kind of 2 sessions. And this is something, if you're using a Lucas device or, something similar, this is something that we encourage you to train on a regular basis. To really make that process really efficient of getting that on. So that's the changes to cardiac arrest at the BLS level. Next one up here is hemorrhage control. Hemorrhage control is actually surprisingly a brand new protocol. It was previously named tourniquet application, but kind of understanding that there's more to hemorrhage control than tourniquet application. They got rid of tourniquet application, renamed it, copied and pasted for the most part, and now it's called hemorrhage control. So it's more of a name change with a couple of small additions in here. The biggest addition is the last kind of bolded bullet point at the bottom here that says you can apply a junctional tourniquet if available, trained, and if bleeding site is amendable. So that begs the question, what is a junctional tourniquet? A junctional tourniquet is not a traditional tourniquet in any way, shape, or form. I'll show you a picture here in a second. But understand there's no requirement for services to do this. If you opt to utilize junctional tourniquets, that's absolutely fine. But you're going to be responsible for training your people. And that will be based on the manufacturer's guidelines. There are several different manufacturers out on the market. When I looked kind of quick online to see how much do these how much do these things cost, there were a couple $100 a piece. They look like this. This is one example. This is the SAM version of it. And when I look at it, what I really see is, hey, it looks a lot like a pelvic binder, and it really is. So these are designed to basically compress hemorrhage that is otherwise that you wouldn't be able to use a traditional tourniquet on because they are at one of the junctions of the body. So armpit, groin is what we're talking about here. So if we can kind of imagine someone bleeding from kind of that crease of the groin there, that inguinal area there, we wouldn't be able to put a traditional tourniquet on there because the wound is just too high for it to work. So if we can kind of see in the picture here, there's little pads kind of underneath, and then those little pads are connected to this tubing, and the tubing is connected to what looks like really a blood pressure the squeezy part of the blood pressure cuff. So the way that this would work is you would center that kind of pad over the wound, inflate that blood pressure cuff looking thing until enough air goes into the pad to compress that hemorrhage and stop that bleeding. Now, if you're not using junctional tourniquets, manual pressure still works absolutely fine for this. These were really designed for situations where manual kind of compression of this hemorrhage at this junctional site really couldn't be done due to the transport times or whatever. These are used a lot in military when we're doing air evacs, things like that, where there just aren't enough people to hold this hold direct pressure for an extended period of time. So again, if your services wish to purchase junctional tourniquets and deploy those onto your ambulances or units, absolutely fine. You have every right to do that. You'll have to work with your manufacturer and your vendors to get training on those. Understand also that we're not putting these online with our paramedic units or our Durham ambulance down there hanging out in Durham. But so what that means for you is that if you're unsure on how to use it, our paramedic is not going to be trained on it and not going to know how to use it because we're not training on any of these devices. Restraints. There was a bunch of restraint changes at the paramedic level that we're not going to get into. The only thing I really wanted to kind of mention here is that there's a new kind of, not a new scale, but a new to the guideline scale that's going to be used at the paramedic level. And oftentimes is already used at the paramedic level in a lot of instances, but it just kind of made its way into the guidelines. And that scale is called the Richmond Agitation Sedation Score, or RAS. This is just here for kind of your own kind of general knowledge of if you hear about a RAS score or a Richmond score or an agitation score, something along those lines. This is what they're talking about. So it's a scale of a -5 to a +4, with 0 being kind of normal, right? So if you're a 0 on the scale, you're alert and you're calm, you're living your everyday life. If you're a -5, you are unresponsive to painful stimuli, like you are out, 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 out. If you're a +4, this would be danger to yourself. The term excited delirium is kind of going away, but it's like that type of patient population. They're violent, combative, danger to themselves, danger to others would be a +4. And then you can kind of fill in the middle a little bit here. What we use this for in the paramedic world, we use it for a couple of things, but the biggest thing, where we use it kind of the most is when we're transporting patients that are intubated and we're trying to keep sedated. We use this score to kind of gauge how much sedation they have and what medications they may need to get to the required amount of sedation. It's being used now in kind of the restraint protocol, really as a documentation mechanism, so that if a patient does get some sort of chemical restraint, we're saying, well, on the Richmond score, they were a +4. I gave them X amount of X medication, and now they are a -3 or a -4, right? It's just more clarifying. Now, understand that this RAS score, this RAS assessment, it assesses sedation and agitation. It does not necessarily replace, it is not a mental status thing, right? It is not a GCS. It's not a replacement for a GCS. It's measuring how angry or how sleepy somebody is. I believe this is the last one for the day. Here is a little bit of guidance on ventricular assist devices, which are definitely out there in the community. They've been out there in the community for a while. They're really awesome technology, really cool technology. But at the very basis of what a ventricular assist device is it is a pump. It's actually a very, very simple pump. And in fact, so we can kind of see here in the pictures and the diagrams, we start from the left. In the A picture here, that's a device called a HeartMate 2. On the right in the C is a HeartMate 3. And those are the two most common ones that are kind of out in the community. And whether you have a HeartMate 2 or a HeartMate 3 really depends on when you had that device installed. It's no different than, what version of the iPhone do you have? Well, it most likely depends on when you bought it. Now, they all have everything here is the devices look a little bit differently, but they function identically, really. So the way that a VAD works, or it's going to be a left ventricular assist device. It could be a right ventricular assist device. It can be what's called a BiVAD, which assists both ventricles. But really what it does is it takes your blood out of the heart, it throws it through the mechanical pump and puts it back into the aorta. Right. So if my left ventricle isn't really functional because I have, severe CHF in my left ventricle, just isn't doing the job anymore, well, the pump does the job of the left ventricle. Right. And when these first came out, I don't know, 20 years ago, these were designed to really be a bridge to transplant. And it would really just buy patients a little bit of time. And the whole goal was, I'm going to put the LVAD in for however long and hope that a transplant or a heart becomes available on the transplant list. Now, because the technology is kind of advanced and they've been fine-tuned and really kind of, almost perfected here, people are having VADs for longer and longer periods of time, which means that they're going to be, out in the community more and more and more regularly. And I know that there's a couple of these around Middlesex County. Now, the hospitals that are installing these, that are the VAD centers, are the ones that you would expect. It's the Hartford, the Yale, the St. Francis, the big institutions here. Now we can see, we can certainly see, like in any diagram that you look at here, big tubes, big mechanical structures implanted in the chest. We have wiring that comes out of the chest through a surgical site. And then we have our kind of control panel or a control module down, which is typically connected to a belt. All of these wires, they can be they're plugged in and they're locked in there, but like anything, they have the ability to become dislodged. And if they do become dislodged and the pump stops working, well, if the pump is essentially the left ventricle and the pump's no longer working, it means cardiac output isn't happening, and this patient is, for all intents and purposes, dead. These are battery powered. Depending on the model, you'll be able to see the battery pack. These patients have a lot of family support, caregiver support. They're in constant contact with their VAD team at their respective hospital. On their person at all times, they'll have spare batteries, they'll have spare parts, and they'll have typically a laminated card that has the VAD coordinator's phone number on. And if there is a VAD problem, one of the first things you should do is call that VAD coordinator and say, hey, your patient, patient Joe Smith is one of your VAD patients. I'm with XYZ EMS. We're here. They're complaining of chest pain, or they're short of breath, or, whatever. And they're going to give you kind of guidance as to what it is you should assess for, what it is you should do, and where you should transport that patient. Now, what the state's providing guidance on here is, well, what if we walk in and we find one of these VAD patients that is unresponsive and apneic? So could be in cardiac arrest. They're definitely unresponsive. They're not breathing. And, if this were a non-VAD patient, we would, check a pulse. And if no pulse, we would start CPR. We can't kind of go down that traditional route because a lot of the VAD patients won't actually have a palpable pulse at normal. And the reason for that is, you got to think, they're no longer relying on their heart contracting and relaxing and creating a pulse to circulate blood. Instead, they're relying on this pump that's kind of just constantly running. So without that systole and diastole, there's no palpable pulse. So our kind of decision tree and our assessment has to change slightly to kind of accommodate for that. So the first thing that we should do here is, if we have an unresponsive apneic VAD patient, is do the obvious, BVM ventilation, right? And OPAs and all of the things that you would look for. Next thing we do is we're looking for clinical signs of perfusion, right? And so in I want to say a normal patient, but in a non-VAD patient, that would be a pulse check. But pulse check really isn't something that we can do in these patients reliably. So we're looking really at like capillary refill. We're looking at the skin color and condition. And if they're, warm, pink, dry, good cap refill, they have good perfusion, we're good, right? We're going to continue to ventilate them, and we're going to try to figure out, why are they not breathing? If they don't have signs of good perfusion, or I should say they have signs of poor perfusion, we don't jump directly to CPR. Because if we kind of look at this picture, we can understand how doing chest compressions on a heart that has, PVC piping running through it could be detrimental to that heart. So the first thing that we do is, if we have, again, a VAD patient, unconscious, unresponsive, apneic, signs of poor perfusion, so they're pale, they're clammy, they're cyanotic, whatever that is, we look for any obvious VAD issue. And this assessment is a second thing. This isn't like taking 3 minutes to go and look and troubleshoot the machine and all of that. That is, hey, is anything unplugged, is really what it is. Or is the battery dislodged? And if things are unplugged, the solution would be plug them back in. If the battery is dislodged, the solution would be put the battery back in. Now, if we have one of those obvious issues, we fix it, and then we kind of go back and think, like, well, did that fix the problem? And if that did fix the problem, we're kind of out of the woods. We're in an okay spot. If there weren't any obvious problems, we're going to apply our AED, right? And we're going to let it do its analysis, and we're going to defibrillate if indicated to do so, right? So AED first. If the AED delivers a defibrillation, we go back and we ask ourselves, did that restore perfusion, right? So far where we're at is, we have our unresponsive apneic VAD patient. We walk in, We're like, uh-oh, this is a bad situation. We're going to start BVM ventilation. We're going to assess for perfusion. If perfusion's bad, we're going to look for anything that's unplugged. If nothing is obviously fixable, we put on the AED. We go into AED analysis and shock if indicated. If the shock's either not indicated or it doesn't restore perfusion and it doesn't restore signs of adequate perfusion, then we go into external chest compressions. Right. So in order to get to chest compressions here, we're already doing ventilations. We have signs of poor perfusion. We don't have any obvious VAD issues of things being unplugged. Defibrillation either wasn't indicated or didn't fix the problem. If all of those kind of benchmarks are met, on we go to external chest compressions. Now, the other thing that should be happening here, in relatively quick succession or, via your partner or another person in the room is contacting that VAD coordinator on that phone. And chances are the family members have already done so. They're already on the phone with that person and they're already going to have all of that guidance. And also chances are that the family member that's on scene or caregiver or, whoever knows way more about that VAD than you and I or ever will know about that VAD. They get extensive training on it as family members and support. So they, realistically, from kind of a pragmatic perspective here, if we're arriving on scene of this patient, chances are the wife, husband, spouse, whoever, has already gone through all of this troubleshooting of the VAD in conjunction with the VAD coordinator. But if they haven't, this is the process that we follow. Now, some of the things that the VAD coordinator may ask you to do is listen at the chest, see if you hear like a hum or, if you can hear that pump working internally. They may ask at the paramedic level to go in and start working on, ACLS medications. But those initial steps are the ones that are the big ones. The reason I put this picture on the slide is really the asterisk down the bottom. If there is an obvious, easily correctable issue with the VAD, such as the drive line, which is one of those wires that gets pumped in that's visibly disconnected and just needs to be reconnected, do that first and then move on accordingly, whether that fixes the problem or not. So we'll review here. One thing I'll kind of plug here is to make sure that you're getting into those guidelines or that summary document and giving it a read, making sure that you're kind of up to date and caught up. But we started today with the EMT EMR intramuscular naloxone. So the intramuscular naloxone, not endorsed by Middlesex at this time, simply because we have widely available intranasal routes that are just a safer option. EMR epinephrine auto-injector. So that's the EMT scope of anaphylaxis EpiPen being extended down to the EMR level. Additional training is required by your department if you wish to do this, and we'll be more than happy to help you with that additional training with the toolkit that we've created. EMT IM Epi for severe asthma. So again, same kind of auto injector thing, but we're adding in severe asthma or asthma with respiratory failure. Really advise against doing this unless you're 100% sure. And this is something that we will not be endorsing if we have the option to not endorse it. And more communication will follow with that. The pediatric urgent crisis centers. Again, maybe an option for the future. Don't think the policy or the protocol is written, especially that reimbursement kind of financial piece to it isn't quite there yet. It just doesn't kind of make sense for us to do at this point. But again, maybe something in the future. The intranasal benzodiazepines, it's your Valium or your Versed. Same guidance as giving the rectal diastat, but as a nasal administration versus a rectal administration based on the prescription and the directions of the patient's physician via that prescription. Aligning with AHA for cardiac arrest. So the big things are 30-2 at the adult level, at least 30-2 for everything. and then two-person BVM and Lucas after about 8 minutes or so, 4 cycles. Junctional tourniquets are an option for your service should you wish to do them, but that training is going to be done in cooperation with whatever manufacturer or whatever vendor you choose to use, if you choose to do it at all, and certainly not a requirement for you to do so. We talked a little bit about that Richmond agitation sedation scale or score. It's more as general awareness that it's something that's out there, really a way of kind of judging how sleepy or how angry somebody is. And then we finished up with the VADs of if you have that apneic, unresponsive VAD patient, doing your BVM ventilation first, looking to see if there's any obvious VAD problem. If there's not, putting the AED on, and if ultimately if the problem isn't fixed by those couple first steps, then going into chest compressions and contacting the VAD coordinator and really kind of following that VAD coordinator's guidance and instructions there. Now with that, here is the QR code, and I will throw, sorry, wrong button. And I will throw into the chat the link for that as well. There we go. Let me just pull the chat box up. All right, maybe I'll throw it in the chat. Let me just find it. And I'm also going to stop recording here.